someone's voice will crack a little bit when they call and say, "Is this who I call for breastfeeding help?" And I'm like, "Oh, I'm here for you. What's up?"
Yeah. Okay, today we have Sally with us, and I'm so excited to visit with you about your work. I love what you do and love hearing you talk about it.
Thanks.
Will you introduce yourself a little bit?
Sure. I'm Sally Wright. I live here in Utah. I grew up in Hawaii. I'm from Oahu. My husband and I met and married in Hawaii, and we moved here ostensibly to have our bachelor's degrees finished at Utah State. So this was supposed to be like a 2-year stint. And 20-something years later, we're still in Utah because Utah has been pretty good to us. And we have grown our family. We have 5 children. I have 3 singleton sons and then a set of girl-boy twins also. My family keeps me pretty busy. Nobody's a baby anymore. My youngest are 10 years old now. We've got 2 dogs. We love to play with our dogs. I've got, my one daughter is involved in figure skating right now. My boys all love basketball. We have a full calendar. And that's mostly what's keeping me busy for my real life.
Awesome. So today we're going to talk to you about your work. You work with mothers, usually new mothers, right? Will you walk us through what it is you do and what your job title is and all those things?
I really love my work. I am an international Board Certified Lactation Consultant, so an IBCLC. And I am in private practice with a practice called MotherFed in downtown Salt Lake. We serve families from all over, but our office space is in downtown Salt Lake. And there are 4 of us that work together as IBCLCs, serving families. I help people figure out how to feed their babies. That's what I tell my children that I do. That's what they tell their friends or anybody who asks, what does your mom do? I love my work so much, and I recognize that when I say what I do often, it turns into a boob joke. Okay. And when I go to like my husband's work parties or other social events, and I say, "Oh, I'm a lactation consultant," immediately there's a little joking about, "Oh, well, you must see a lot of boobs," and I always laugh that off, but that's actually totally not what my work is about. I'm very invested in the people that those breasts are attached to, and so I work with families. And I love babies, but I'm in this work for the parents and the mothers and other nursing parents who are working hard to figure out how to feed their babies and meet their babies' needs. So when I'm asked what I do, I say I help people figure out how to feed their babies.
That's awesome. So tell us the difference between what you do versus somebody in the hospital that helps with breastfeeding, or even a midwife or a pediatrician when they offer their feeding help. Why would somebody want to go to you versus just do it?
That is such an excellent question. There is a whole scope of different credentials and I should say a whole continuum of different credentials, and each of them has a different scope of practice. I think it's the United States Lactation Consultants Association has a really excellent graphic, if somebody wanted to Google that, where it's a chart that has like all the alphabet soup of all the credentials and what specifically their scope of practice is. But I can summarize it pretty briefly. You have peer support. Sometimes that is like, there's an organization called Breastfeeding USA, or La Leche League is the one that is present here in Utah, and I am also a La Leche League leader. And that's peer support, and a peer support person offers information and support. They are not offering clinical care, and they don't pretend to. But sometimes that's exactly what you need. Sometimes when you're having a moment of stress, or just even a moment of wondering where you're like, is this normal? Am I still on the right track here? A La Leche League leader or other peer support person can absolutely, even WIC has peer support people, they can help you troubleshoot and say, well, this is the information about what is the range of normal. Does that match what you're experiencing? And you can say, oh, yes, totally. Oh, good. Sigh of relief. Or you can say, oh, no, that's actually, we're not there. Maybe I need to keep asking questions to and seek out clinical care. On the other end of the continuum is an IBCLC, an International Board Certified Lactation Consultant. And typically she, has the most clinical training, the most hours of experience. Before you even sit the exam, you need to have at least 1,000 hours of contact with nursing parents and babies, in addition to 90 hours of lactation-specific education. In addition to either being already part of an accredited, like a medical professional, or having taken college courses that would meet the prerequisites to pursuing medical professional training. So that's the most thorough training. Now in between we've got a whole bunch of what I think of as alphabet soup, because it can be really confusing for consumers. There's a CLC, a Certified Lactation Counselor, and a CLEC, a Certified Lactation Educator Counselor, and a few others that are certified through different organizations. Most of those are add-on credentials. Most of those courses are either 2 or 4 day courses with a test at the end. They don't require lots of clinical contact hours. They don't require anywhere near the 90 hours that's required for the IBCLC. And I think that those credentials, people who hold those credentials can often offer excellent help, but typically it's more like information and support. It is not clinical care. That's an opportunity for someone who, like a doula, or it's an add-on credential in my mind, a doula or a nurse. Like if someone was a labor and delivery nurse at a hospital and was routinely in contact with newly postpartum parents and new babies, they might want to pursue one of these credentials as an add-on, so that they would be better qualified to help and troubleshoot and also recognize when a dyad was having a hard time and needed to be referred out for clinical care. The lactation consultant name is actually only to be used by an IBCLC. So I think sometimes people just don't know that anybody who's doing anything related to lactation is a lactation consultant, but actually the consultant is the IBCLC. Sometimes people will use the word specialist. There's no credential that's a specialist. Everyone's a specialist. If you've ever lactated, you're a lactation specialist. If you feel special, you're a specialist. It's not a credential. So to me, I would think that starting with, if someone were having trouble, starting with peer support to get really good personal information and accurate information and personal support would be the ideal place to start, to troubleshoot, to decide if they're still in the range of normal or if they wanted to seek clinical care with an IBCLC and possibly get a referral. Pediatricians and midwives are absolutely part of this, because midwives care for postpartum people all the time. Midwives are experts in normal pregnancy and normal birth and normal postpartum. They are typically not specialists in lactation in any way. But they have a lot of experience with the postpartum time period. So they can often pick up on things that are normal or not normal, but ideally they refer out to an IBCLC if they don't hold that credential or have the time to thoroughly assess because of their own client load. And pediatricians, similarly, we have several pediatricians who have been our clients at MotherFed, and they're wonderful. Everyone we have worked with who is a pediatrician or a pediatric surgeon has commented multiple times in their work with us, this is not what I learned in school. Infant feeding was an elective, lactation was an elective, it was one class, it was like a brief discussion of how breastfeeding is a good thing to do, and that's all. Amen. Yeah. But not really related to clinical care of the lactating person or the baby. And I like to think of pediatricians as experts in normal growth and development and prevention and treatment of disease and injury. But if a baby is growing and developing normally and is neither sick nor injured, there is perhaps not a need to understand all the exact details of how that baby is growing or being fed. So those details are somewhat more nuanced, and a pediatrician may or may not have pursued the additional training necessary to know how to support a breastfeeding relationship or lactation. And I think that's something that people forget.
So I want to ask you a little bit. You've talked about normal, and I've heard you speak about the range of normal. And I love when you liken it to walking is normal.
Oh yeah.
Will you explain a little bit, how someone would know what's normal and what's not normal? If I'm first time feeding my baby, is this normal? And how do you know if you need more help?
I think it's important to differentiate between what's normal and what's common, because I think lots of people have very difficult and discouraging breastfeeding experiences, especially in the early days. And I'm not invested in normalizing breastfeeding being horrible. I want to honor the grit that is new motherhood and new parenthood and expanding your family. Families in our culture are under a lot of pressure to cherish every moment, and there's a lot that doesn't need to be cherished because it can be gritty and exhausting. But I don't want to normalize suffering, and I don't want to normalize everything that is common. So it is common to deal with engorgement postpartum, where lymphatic fluid and the onset of lactation causes congestion in the mammary ducts and glands, and causes uncomfortable swelling in the breast tissue, and that needs to be addressed because chronic engorgement can lead to low milk production. If we're not moving milk out, it's sending messages to the body to slow down the milk factory. So we need to address that. It's common, but it's not normal. When postpartum parents and babies are left with good support and encouragement, and basic knowledge in how to manage breastfeeding right from the start, terrible painful engorgement is not typical. Doesn't typically happen. But that's not always the case in our culture. So engorgement, I think, is an example of something that is common but not normal. What else are you thinking of?
I just liked your description of, walking is normal, but not everybody walks at the same pace, and some people even need a walker or a helper as they learn to do these things. So obviously, we typically think breastfeeding is the normal or what we are designed to do, but sometimes there's other things that play into it that can make it difficult or take a little bit longer to figure out.
Absolutely, and that's something that I think needs to be validated and explored a lot. I really enjoy thinking about breastfeeding as normal infant feeding because our culture tends to frame it as like advanced level, AP honors infant feeding, like
it's
shoot
not
for the
benefits,
moon,
but it's not.
There's no benefits.
It's just what
normal.
It should be normal.
And I tend to look at breastfeeding as this is normal infant feeding, but that gives us a lot of freedom and flexibility in that if we run into challenges, we can reach outside of where breastfeeding is normal, but we're not in a normal situation. My baby arrived 10 weeks early, or my baby's very sick, or I had a mastectomy, or whatever, like any of a million different situations. Like, how can we make this our situation that's out of the range of normal? How can we maximize normalcy? And maybe that's donor milk, maybe that's pumping and feeding, maybe that's using different tools or equipment, but always with the goal of working towards normalcy or maximizing normalcy. Maybe we have low supply, so we need to supplement, because feeding a baby is never we're never questioning whether or not we should feed a baby. But we want to maximize normalcy. And I think the comment that you're alluding to that I have said in the past is that breastfeeding is normal like walking, but not normal like breathing. Breathing is a reflex, and most of us, barring health problems, just do it automatically. And there's a little more to breastfeeding than that. There are in fact a lot of reflexes involved, but both parties need to be set up to have it work well. And that makes it a lot more like walking, of like taking your first steps and then falling down. Okay, this morning's feedings went really well, but this afternoon we're tired and we're falling apart. We need some help. Are we doing this right? And you can stumble along a little bit, but eventually we move forward with with the typical walking that we expected to. And same with infant feeding.
Yeah. So tell us how you became interested in this line of work. How did you know this is what you wanted to do?
That is a good question. I think I have thought about this before because I can remember in high school many years ago taking all kinds of interest inventory tests to help us, that the college counselors were trying to help us determine what are your interests and what are your aptitudes and what kind of career might that translate into, and then what kind of job training would make sense. And I can remember doing all of those, and I think that if I could go back in time and tell my 17-year-old self, you are going to be a lactation consultant and it is going to be your life's work, I would have just rolled my eyes and I was like, are you kidding? And I probably would have made a boob joke.
Yeah.
Because I didn't know anything about how important this would become to me. My degree is in communication, and I worked as a journalist, as a newspaper reporter, before I had children of my own. When I became pregnant with my first child, I took it on like an academic study. I wanted to know everything about the science project that was growing in my body, and how to take care of it and how to address it, and eventually this little person is going to come out, and then what comes next. And so I read all the books. As much as I could learn, I asked women around me who were mothers about their experiences, and I picked up on a few themes of just different themes of and different styles of mothering, and that helped me to sort out what made the most sense for me. And then when my son was born, he was very sick, and we spent about a month off and on at Primary Children's Hospital in Salt Lake, being really worried. As it turns out, he's fine. He's a great big healthy strapping young man now. But that was a complicated and emotional time for me as his mother. There were surgeries discussed, there were scary tests ran, and I remember feeling immense pressure. It was like baptism by fire into motherhood, because I remember feeling like people were calling and sending notes and contacting my husband and I to, make sure we were okay and had enough cookies in our life, and that was wonderful. But I remember feeling like I need to get it together, because if I answer the phone and sob from worry, then people will be terrified for me and my baby. But I'm the mom. I have to be okay with whatever is going on. I have to present that this is hard, but we're dealing with it, and we trust our medical team. Because if the mom is okay with things, if the mom's okay, then everyone else can be okay. And if my little baby had to face a complicated surgery or a long recovery, and as it turns out he didn't, but still I was looking at it in the eye, this distinct possibility, I thought, I have to be okay with this. I need to learn everything I can so that I can tell people, well, this is what's going on, and this is the treatment, and this is why we're okay with it. And so I pursued everything related to motherhood as an academic project. I wanted to know everything so that I could handle it better. It's probably a trauma coping technique, but it absolutely helped me get through that hard time. Well, I was absolutely invested in breastfeeding, and the gastrointestinal problems that my son was dealing with brought that into question. Well, how all of a sudden we had to really seriously consider, well, how should we feed this baby who might not be 100% well? And the gastroenterologists at Primary Children's put me in touch with the IBCLCs there, and I worked closely with them. And I was very impressed and grateful that none of them were just going to shrug and say, or don't breastfeed. Yeah. Everyone I worked with there was complimentary of my commitment and ready to help me continue to nurse my baby, even through complex challenges. And then so I had excellent support. I feel like I had good base knowledge in theory, and then when it became practical reality with a baby in my lap who wasn't feeling good, I also had excellent support of people who were willing to help troubleshoot and still preserve normal infant feeding as much as possible. And then when we were discharged from the hospital, we were so glad to go home, but I still had questions. We were healthy enough and sturdy enough to be at home, but I was still a brand new nursing parent trying to figure things out and trying to figure out how to mother this baby. And I still had questions that maybe were less clinical. When I called to speak with the IBCLC that I had worked with at Primary Children's, she referred me to La Leche League, which is a nonprofit, non-sectarian international organization that is devoted to helping families who want to breastfeed get accurate information and support to do so. And that is when I do feel like the world shifted a little bit. When I made a phone call to a La Leche League leader who is based in Garland, Utah, and asked her all my questions, and she was so kind and so supportive and so helpful. And I do feel like the earth moved the day that I made my call to a La Leche League leader, and I felt weird doing it. I remember thinking, I'm calling a stranger to ask her about my nipples. How, like, is this weird? And it wasn't weird, because the woman who picked up the phone is absolutely wonderful. And she helped me with my questions and helped me troubleshoot some things. Again, none of these things were of clinical urgency, but I did need some friendly support. From someone who actually knew what they were talking about, not someone who was going to tell me the horror story of their own disappointing breastfeeding relationship, because that's that wasn't what I needed. And I didn't want to be in the place of needing to validate someone else's stress while I was trying to sort out my own. But that call to a La Leche leader was the best thing I could have done. And she invited me to an in-person meeting, because the Leche League typically offers monthly meetings, sometimes more often than monthly. The pandemic has changed some of that in different areas. La Leche League in Utah now, across the U.S., is meeting via Zoom, but then at that time we still had in-person meetings available, and we hope to go back to that too. But I said I would go to this meeting, and as I was pulling out of the driveway, I said to my husband, and this is what is kind of a family joke now, that I pulled out and I said to my husband, I'm going to this meeting, I don't know if it's weird or not, but they were super nice and helpful to me on the phone, so I'm gonna go, but I don't think I'll be gone very long, because for reals, how much is there to say about breastfeeding? And that was the baby that was in the back seat of the car at that time will be 20 on his next birthday. So we're talking nearly 20 years ago. I said, how much is there to say about breastfeeding? And as I found out, there's actually quite a lot. And I have neither learned nor said it all yet.
Yeah.
But that was the start of a whole series of wonderful relationships and information and knowledge that I had not previously, it hadn't even been on my radar. And so it was exciting to learn new things and to see how much it enhanced the relationship that I had with my baby. I went on to become a La Leche League leader, again, which is part of that peer support umbrella on our spectrum of lactation helpers. And I still am a La Leche League leader. I think it's 15 or 16 years this year. And so I helped with peer support meetings and answer questions on the phone and online. I admin for a couple of La Leche League Facebook groups, including the one for multiples, for families with multiples, because my twins made me better at my work, absolutely. And then it was around the time that my twins were outgrowing our nursing relationship, and it had been a dream that I just wanted more and more information. I wanted to be able to become an international board certified lactation consultant. But when my twins and I were graduating from our own nursing relationship, that is when I realized I am not getting tired of this. Perhaps this is the end of my own nursing season, but I am not outgrowing my passion for offering breastfeeding support. And I would like to be able to do it with more credibility and a greater scope of practice. What if I could be trained to offer clinical care beyond the information and support scope? And so that is when I went back to school to take my health science classes and to get those prerequisites done and work towards sitting the exam. So that was 6 years ago, and so I have been in practice for 6 years
Awesome.
with mother-fed. So that's the story of
how you did it.
how it came to be. It was absolutely personal experience,
Right.
coupled with just a genuine curiosity and enthusiasm for the content, and seeing how much it matters that the clinical information does matter. Like knowing that, here's something that I say very often in almost every consult. This is like a free tip to anyone who's newly postpartum and working on things if they happen to be listening to this conversation. The chin needs to be anchored against the breast tissue. The baby's chin needs to be touching something.
Mm-hmm.
That is what stabilizes the jaw and triggers the gait,
Mm-hmm.
to be able to want to latch and feed. And so often we try to put something directly in a baby's mouth, and when we do that, they'll act like they can't find it. Because there's nothing about poking something in their mouth that tells them to stabilize the jaw and prepare to eat. So just simple positioning tricks and things like that are absolutely rooted in biology and the science of reflexes make an enormous difference in how frustrated or not frustrated an exhausted newly postpartum mom feels trying to connect and just make things happen while she takes care of this brand new baby.
Okay, so I had a consultation with an IBCLC with my 8th baby. So it wasn't like I didn't know how to nurse, but there were outlying issues and I knew something wasn't right. Will you tell us what a typical consultation looks like? Maybe you start with a phone call, or they schedule, or how, what does it look like? I'm guessing most moms, when they get to the point that they're calling you, they're desperate or pretty emotional.
This is true. My colleagues and I joke a little bit that if we were going to rename our practice, we might call it Last Ditch Lactation, because many of the conversations start with something like, "We are miserable. Nothing is going right. We've gotten discouraging news at the pediatrician's office, and I don't want to quit breastfeeding, but it's not going well. I'm going to meet with you and see if you can tell me anything." That's a pretty common refrain. And I often think, gosh, I wish you'd called 2 weeks before it really went off the rails. Like, didn't have to get terrible.
Right.
But we can work with wherever you are. I can also often tell when it's day 4 postpartum, and that varies a little bit depending on the time of day that baby was born. But usually day 4 is when the euphoria and excitement wears off and the fatigue hits, and if things haven't been going well, it kind of comes to a head on day 4, and that's when someone's voice will crack a little bit when they call and say, "Is this who I call for breastfeeding help?" And I'm like, "Oh, I'm here for you. What's up?"
Yeah.
And it's almost always around day 4 when a conversation starts like that. Exactly how a consultation unfolds will probably vary from IBCLC to IBCLC. And a distinct difference here to note is that I'm in private practice, and so that means that a consultation with me or one of my colleagues takes about 2 hours. We pride ourselves on being very thorough, and we're not really interested in having someone stop by and for us to make declarations about the state of, "Oh, well, I see, do this and this, bye-bye." Because we don't find that that's super useful for retaining information or for us getting a full, accurate picture of what's really going on, or even for an exhausted parent to feel like they had to run an errand. We want people to be able to come and be comfortable so that we can get a really good assessment. So in our practice, we always do a weighed feeding as part of a consultation, where we weigh the baby and then feed the baby. If the baby's at the breast, and we want to see how much milk baby is transferring, then we do a second weight, and we can deduce how much milk they're moving at the breast. Because again, sometimes it's a management issue where someone's not feeding their baby often enough. They're not nursing often enough. And sometimes it's a transfer issue where there is milk to be had, but the baby isn't removing it effectively. So we have to troubleshoot what's going on with the baby. Maybe there's something anatomically going on in baby's mouth preventing effective transfer. Or maybe baby's doing everything right, but we have low milk supply. Well, why? Let's troubleshoot that and see what we can do. And in the meantime, how can we keep baby well fed and strong to be able to bring us back to normalcy? Or maximize normalcy while we work through a challenge. But we always do a wave feeding. We watch babies eat, whether it's at the breast or with a bottle or with another tool. We want to see how babies coordinate, suck, swallow, breathe. We are often in contact, depending on how far in advance someone made an appointment, we're often in contact to find out basic things about sleeping and stooling patterns. And we always do a really thorough oral assessment in the consultation as well of the baby to see what oral mobility and oral function looks like, to see if there are points of tension. So an oral assessment is something that we always do in a consultation. We do a really thorough oral assessment where I glove up and I'm looking into the baby's mouth to assess oral mobility and function, specifically as it relates to feeding, to see if there are any points of tension or restriction. Some people come in with a family history of tongue ties or lip ties or just questions about it. Maybe they know somebody who had trouble breastfeeding because of that and want to make sure that that's not contributing to their trouble, to help rule that out. And so we're looking to make sure that babies can lateralize their tongues and have good elevation of their tongues so that the tongue can perform the full peristaltic wave that's necessary to maintain latch at the breast and also effectively remove milk. The tongue is really the motor of breastfeeding. The lips and the rest of the mouth just need to be able to maintain a good seal. But the tongue is the part that needs absolutely normal mobility to effectively remove milk. And this is where there's a difference between compensation and competence, because sometimes baby does have restriction and does have points of tension, but babies are smart and they like to eat and they want to be fed, and so they'll make it work for a time. Sometimes that gets us through for a little while, and sometimes that's not enough milk removal to keep babies well fed and comfortable or to maintain lactation in the mom, and we start to see supply drop without any intervention or assessment for what else we can do. That oral mobility is key, and that's part of every assessment for us when we're troubleshooting. And we also can do flange fittings if someone is using a pump, whether they're using a pump to get through a challenge or whether they anticipate using a pump because they're headed back to work or school. We want to make sure that their gear is all working perfectly.
Okay, so you had talked a little bit about when the moms first call you and they tend to be stressed, we'll say. So I want you to share a little bit of your thoughts on that responsibility to be able to step in and offer some relief and help at such a vulnerable and emotional time.
It feels like it is so important to me. It feels like, well, depending on how things are going, it can feel like treading on holy ground. Mm-hmm. And I want to tread very lightly and very gently there. It can also feel like I have a backstage pass to the most beautiful show ever. Mm-hmm. You've cheesed me up, Angie, and now you've made me tender about my work. But, and this is not to say I'm tender about it, but it isn't because everything is always beautiful. It's because I do get to see people in dealing with some difficult, gritty stuff. Mm-hmm. Where things are, their reality is not matching their expectations at all. And sometimes that's really hard. I feel immense responsibility to make sure that I am guarding my language and speaking carefully, because postpartum people are exhausted and vulnerable, and I do not know which things I say are going to stick. And I routinely am talking to people who start their conversation with me with, well, the nurse at the hospital said that my nipples are weird, so I won't be able to breastfeed. And I'm like, what? Like, you don't even have to lift your shirt. Your nipples are perfect. I know that. I know that.
Yeah.
Your baby is not shopping in Target comparing the wall of artificial nipples to what you have in your bra. Your baby is not comparing. You have what your baby needs. I want to make sure that I'm always speaking, even when there's very real and complex challenges, I want to make sure that my words are supportive and encouraging and validating, not to gloss over trouble, but to always say, it's up from here.
Yeah.
I don't want to be a memorable part of someone's postpartum experience. At MotherFed, we focus on, we're very hands off. Almost always when I describe my work, people will tell me horror stories about negative experiences with a lactation consultant or other breastfeeding helper, often in the hospital, but sometimes not, where someone grabbed them or touched them inappropriately without consent. And our philosophy is very hands-off. Like, I will often sit on a sofa next to a mother with a doll and say, and I will hold my doll and say, what happens if you move your baby this way? What happens if you position your baby more like this? And then let her do it. I want her to go home and be able to do these things on her sofa. I don't want to get in there with my hands and make all kinds of adjustments, and then she goes home and is like, well, the lactation person did it, but
No, I don't know how.
but I don't know how. Like, I'm right where I started. I want her to have the experience of doing all the manipulation and adjustments and success and competence. I want all of that to be hers. And I don't want to imagine for a moment that I empower anybody, because people already have their power. I want all the power to stay with them. I want to just be their colleague as they troubleshoot and work through things to make it better. But I want it to be focused on them and their new relationship with this new person, as they make things better.
Cool. So how has this job affected you as a whole?
To be a La Leche League leader, I needed to take a lot of communication courses, and that is a primary interest of mine in general. That's my degree. But my degree was in journalism and mass communication, and learning interpersonal communication skills and counseling skills as a La Leche League leader influenced my life tremendously, and helped me learn a lot when to step in with suggestions and when to simply do some active listening and listen and validate. I learned a lot about that. As I moved into the clinical sphere as an IBCLC, I feel immense privilege and delight to be able to work with all kinds of families. I work with families that have a mother and a father and babies, and I work with same-sex couples, and I work with transgender people, and I work with people who welcome their babies through adoption or surrogacy, and I love all of it. In all of it, I feel consistently that every baby is a joy, and that babies in many different circumstances are so eagerly anticipated, and every baby should be so eagerly anticipated, and every parent should have access to excellent, skilled clinical care that is respectful and affirming and thoroughly supports the relationship that they have with their baby. And that's something that I don't think I would have been able to learn and see and participate and find joy in had I stayed solely in a peer support arena, because it is absolutely expanding my scope of care to the clinical level that has made more people with more complex cases want to work with me and my colleagues at our practice. But I love it. Like, one of my favorite calls are people who say, I will be adopting a baby who is due in 6 months. How can is it possible? People want to know, is it real? I heard I can breastfeed a baby that I didn't give birth to. Is that real? Really? And I say, yes, let's get together. We can make a plan for you. We can do that. But I wouldn't have known those details or how to approach that without the higher level clinical training.
Okay, so to wrap up, I would love if you would share some of the things that you've learned through your work and some of the blessings that have come from your experiences.
I think that my work has helped me learn to meet people wherever they're at. Maybe they have lots of experience, maybe they're brand new, maybe they are just wondering, maybe they're not feeling pretty uncertain, and now that they've hit challenges, they're not sure. And I feel like I have learned to meet people wherever they are and also help them meet their goals. I think that sometimes people have negative experiences with lactation consultants when the consultant is someone who cannot differentiate between her own goals and desires and what her client wants. And I do think that's something that I have learned to do is find out more right from the get-go about what someone's goal is, and let's get you to your goal. Sometimes I say, I don't have a magic wand, but if I did and could make everything exactly right for you, what would that be for you? And that their answer gives me a lot of insight. Is this someone who wants to exclusively breastfeed full term? Or is this someone who's going back to work in 2 weeks and wants to just make sure that she can establish lactation to provide milk for her baby while she has to be away? And what are the tools she needs to do that comfortably and effectively? There's all kinds of situations where we have to bend biology a little bit to make sure that we can make life work. So I think that seeing a wide variety of experiences has helped me learn to see that there's also a big range of goals for a breastfeeding and nursing relationship. I know that something that I've learned both through my own mothering experience and through working with other families and nursing parents is that there are no lazy babies. Babies are never lazy. And sometimes people come and they're discouraged and they say, well, I'm doing everything that the books say, but my baby's just lazy and doesn't do it. And I don't ever use that language. I bristle a little bit when I hear it because I feel like it frames a struggling, hardworking baby as having a character flaw, and that can drive a wedge in this brand new, tender, blossoming relationship between an exhausted postpartum parent and their brand new baby. And I don't want any of my language to contribute to that. And so I feel like one of our strengths at MotherFed in general is making sure that the relationship is supported. And that parents can see their babies for the small people that they are, that this is a little person who wants to eat, who wants to thrive, who loves being with you. And so we do some of that reminding too, but I've never met a lazy baby. Every baby I know is working as hard as they can. And if they're not getting enough calories or enough fuel, or positioning isn't quite right, or they've got something going on anatomically, whether it is something orally in their mouth or a cardiac issue or whatever it is, some kind of medically fragile concern, everybody is working as hard as they can, and that includes little babies too. And I've been able to take that idea and extend it to others, even adults that I meet in real life, and I think, well, you're not a jerk. You're having a hard time.
Yeah.
There are extenuating factors here. Probably you missed lunch and that's why you're behaving badly. And it's allowed me to overlook and excuse and get to the heart of the matter instead of feeling resentful about whatever speed bump I may be hitting in a personal relationship.
That's cool. You've been able to apply it. Everybody needs to eat.
We're all a bunch of babies.
Awesome. Anything else you'd like to add?
I love my work. I love to talk about my work. I love supporting relationships. To me, breastfeeding is so much more than a calorie delivery method. It's a relationship, and I know that even as my own children have aged out of our nursing relationships, we have been able to maintain close, responsive, intuitive relationships, and I attribute that a lot to the responsive mothering that I witnessed at La Leche League and with the other people that I saw anticipating and welcoming babies, and the general attitude of delight, even despite messiness and exhaustion and the grittiness of child rearing, but general delight in the presence of babies and children. And I'm so lucky to have had parenting framed that way for me, and to have had people who honored children as people who deserved respect. I'm so fortunate to have that have been my own experience, and it's because of the people I associated with, and I feel lucky forever.
Awesome. Thank you so much.
Thank you.